Hello. Thank you very much for the invitation. I am really happy to be with you again this year. Uh, I will take these two, I'll try to mix these two presentations together and speaking about the need for a second stent in bifurcation lesion and then the role of imaging and physiology. And now we know that we have different scenarios in bifurcation lesions, but what is important is the first thing important is to determine the clinical relevance of the side branch. Then if it is clinically relevant, we should optimize every time and choose the right approach. And about the relevance, it depends on the length and the size of side branch. That means that the myocardial portion covered by the side branch. When it is more than 10% of the myocardium, then it is clinical relevant and can impact the prognosis of patient. When to use systematic two stents? We know that provisional stenting should be the preferred approach for most bifurcation lesions. That means around 70 to 80% of bifurcation lesions of what we are doing every day in our practice. Exception to this rule is when you have a large side branch, more than 2.75, with long ostial side branch lesion, more than 5, what I would say more than 10 millimeters, and anticipated difficulty in accessing an important side branch after main vessel stenting, and through distal bifurcation, particularly in left main. This is accordingly to
my view, the groundbreaking.
I have some disturbance with the audio.
Trial, so welcome.
Hello. Okay. So this is accordingly to European Society guidelines for myocardial revascularization. And now we know that in almost 20% of patients, we are shifting from provisional to two-stent strategy, and this is what recently also shown by EBC main study. Now, the size of side branch does matter in choosing one or two stents. Side branch angle as well, like this ambiguous angle. I think it's good to keep in mind that these side branches with difficult access then might need double stenting, upfront double stenting. Lesion length is very important on side branch. That was also documented by this meta-analysis that when you have lesion length on side branch more than 10 millimeters, then two stents approach will be superior to provisional stenting. And we know that also the other criteria is the complexity of bifurcation morphology. However, what is complex in bifurcation lesion, we do not have a good definition. If we look on what is adopted by EBC, the Medina classification, of course it is very practical classification, but it doesn't include any characteristic of patient outside of the extension of the lesion around the bifurcation, but no other characteristics are defined. And the same EBC recommendation now take in consideration something more about the characteristic or morphology of the plaque, as well as some other morphologic characteristics in order to define the complexity. That means some kind of recognition that Medina classification is not enough. But we know that what we have today is the definition criteria, which was introduced by Definition 1 study, and including 5 minor criteria and 2 major criteria. Major criteria are severity of lesion on main vessel and side branch, and length of lesion on side branch, and minor criteria, other morphologic characteristics of the bifurcation. And then if you have one major criteria with two minor criteria, then this should be defined as complex. And if we look on the outcome, you can see that when the lesion is defined simple by definition criteria, then provisional stenting is superior than two-stent technique. But when we are dealing with complex bifurcation accordingly to the same criteria, then two-stents approach is superior to provisional stenting. And this was confirmed recently by definition 2 study as well. So to summarize, I think that in every bifurcation lesion, clinically relevance should be evaluated every time. But in distal left main, we know that the branch is not a small branch, is almost main vessel. Then if you do not have, if it's not clinically relevant, then it is just to keep it open. If it is, yes, relevant and simple bifurcation, then simple stenting is the recommended upfront approach. And if it is complex, then two-stent technique or elective two-stent complex stenting is the upfront. Intravascular imaging is always recommended in procedural planning, guidance, optimization, because it helps in defining the lesion as well. But we'll get to this later. Now, angiography alone, we know that it is not always reliable for the size, for the length of lesion, and so on. And another important thing is the lesion preparation. That means every time you are approaching, not only bifurcation, I mean in general, I think lesion preparation adequately should be kept in mind every time, because that will give you the security to have a full expansion and full apposition of the stent if you are preparing adequately your lesion before stenting. Then coming to the stenting technique, we know that we have the simple one is provisional, and we have three big families of double stenting. That means the T family, including all modified T and TAP, and the crush family, including mini crush and DK crush, and culotte stenting with mini culotte or DK culotte today, what we are using mostly in our clinical practice. Of course, all strategies have been evolved because we have different platform with different design and more appropriate strut thickness and so on. More detailed data coming from bench testing and clinical practice, so showing that giving us the possibility to better perform our procedures, more use of intravascular imaging and for procedural guidance, more effective devices for calcified lesion preparation, improvement of basic strategies coming with all these evolution, and more clinical data with improved outcome as well. So if you take provisional stenting as well as any other procedure, double stenting and following step by step, that means stepwise approach with intravascular imaging, I think if you look on the final result, both on angio or intravascular imaging, you will see that you can get a good result and for each two-stent strategy or provisional stenting as well. And if we now the question, which approach is the gold standard or the best one? Well, coming to this meta-analysis, can see that all having some pro and some contra, and then if we go to the final score from this meta-analysis, you can see that any of these approaches will have some pro and some contra. But if you look that on DK crush is for two-stent technique as compared to provisional stenting is the lowest, having the lowest score. That means the best performance in terms of clinical outcome as compared to all other two-stent strategies. So to conclude this part, I'll say that upfront two-stent strategy is based on side branch clinical relevance and lesion characteristics, that mean disease severity and long lesion length, or particularly in side branch. Definition criteria for simple and complex bifurcations seems to fit with an appropriate strategy selection: simple bifurcation, simple stenting; complex bifurcation, complex stenting. All the two stent strategies have their pros and cons, but no doubt about the need for good experience, stepwise approach, planning the procedure accordingly to the lesion characteristics and complexity, lesion preparation, and good stent expansion of the position, and the optimization, which is mandatory and associated with a better outcome, particularly if guided by intravascular imaging. It is essential to have a good experience in more than one of two stent strategy and to be ready for plan B, which might be necessary during your procedure. Now, coming to the role of intravascular imaging and physiology, I think, again, angiography cannot provide you all the characteristics needed to define your procedure and to plan your procedure. So in the guidance started from pre-procedure to assess severity of bifurcation lesion, measurement of lesion length, main vessel and side branch size, to determine where it should be your stent landing zone, detection of angiographically silent disease, and to select appropriate strategy accordingly. If you look on some examples here, you can see that angiography cannot define how much is the involvement of the ostium of LAD or circumflex here. That means the two branches of the bifurcation. But if you go with IVIS, you can define very well, and accordingly you can select your procedure as well. And again, the other important thing, the longitudinal view, which can give you some element which you can predict possible occlusion or plaque or carina shifting after stenting in the vessel, and of course can guide you to the size the stent accordingly to the main vessel distally to bifurcation in order to avoid plaque shifting as well. And if you have, in some cases like this, with ambiguous lesion on the left main, you can see, or at bifurcation, you can see that both IVUS and OCT can give you the exact area, the exact degree of this stenosis, and you can decide it accordingly, or you can combine the physiology. And you can see that if you combine it in this particular case, you can see that these areas was associated with the negative FFR, and this patient have been studied in December 2018 until January this year. He's still asymptomatic without any invasive treatment. Now, about FFR, I think Dr. Ansari before had a good presentation, excellent presentation about physiology in these cases. So I think that we can I can limit just the use of FFR in bifurcation. And again, the challenge is most difficult for ostial lesion. That means for side branch, when you have some damage on side branch or some compromised side branch, I think FFR can be very useful in determining whether you have to proceed for more treatment on side branch or not, as well as in distal left main sometimes, but we have some limitation here. So if you are going to evaluate distal left main, you have to study both branches, that means both LAD and circumflex, in order to have more reliable data for the ambiguous stenosis and distal left main. But the main use of physiology, I think, still the side branch after stenting, particularly in provisional stenting, when you have some shifting or some hazening on the side branch, then FFR can help you in choosing or selecting the appropriate approach. Like in this case, after stenting, crossover stenting from left main to LAD, there is some stenosis there or some shifting there on on circumflex. FFR was 80. After ballooning, came back to 0.96, and no other treatment was needed as well. Now, the guidance during procedure and procedure guidance and optimization, of course, intravascular imaging can give you stent, the degree of stent expansion of the position, assessment of through versus child stenosis after main vessel stenting, full coverage of the C segment by the stent, optimized technical result, and stent edge dissection, all elements needed to be sure that everything in place and you are optimizing your work as necessary to have the best outcome. And again, you can see some examples here that showing how the expansion of the stent at bifurcation at the carina, and no bulky accumulation of metal at the carina. So this, as well as areas of in-stent area at each of the branch of the bifurcation, which ensure you that your result is optimal. Another important point that you cannot see on angiography, if you look here, the stent seems to be well expanded on angio, but if you go with iris, you see that there are huge malapposition, and this can predispose for stent thrombosis or in-stent restenosis, and can be only corrected by the use of intravascular imaging, which showing after post dilatation again that the opposition now is much better. And of course, the assessment of during the procedure, that means through versus pseudo stenosis. Again, FFR can help you, but also IVUS can help you in showing whether you have plaque shifting or just one strut in front of the side branch, as in this case.
Dr. Sheiban, we are
now,
over time.
Post-stent dissection, that means stent edge dissection, can be seen also by IVUS, but I think that OCT can give you more details because of more resolution given by this technology.
Dr. Sheiban,
and we have a lot of data, clinical data, showing that the guidance, intravascular imaging guidance for our procedure, and particularly for distal lift main, that means bifurcation, will improve significantly clinical outcome, not only in terms of target lesion revascularization, but also in mortality can be reduced by the use of intravascular or guidance of intravascular imaging during our procedure. What can OCT provide more than IVUS? I think that better resolution, that means more detail on plaque characteristics, can predict side branch occlusion after stenting and carina shifting. Again, stent expansion and apposition, stent fracture. So many details can be seen more with OCT than with IVUS, like in calcification and pre-intervention evaluation can give you more detail about the size of the calcification, as well as the extension of the calcification. Then edge dissection can be seen more, as well as malapposition, like dissection here. And of course, more detail on the coverage of the stent, crossing with the wire to side branch, as well as the coverage during the follow-up coverage of struts with narrow endothelium.
Dr. Sheiban,
my final remarks is that intravascular imaging provides precise characterization and extension of morphology of left main bifurcation and bifurcation lesion. This allows a proper planification of the procedure strategy. Intravascular guidance facilitates the final optimization of the procedure results in left main and bifurcation lesions. Pooled analysis of studies shows a significant and consistent clinical benefit of IVUS guidance. FFR evaluation in left main disease is reliable and safe to avoid unnecessary treatment, but should be appropriately performed. I think both physiology and intravascular imaging need a good training and good experience for execution and most importantly for interpretation. Thank you very much for your attention.
Thank you. Thank you for a great talk and excellent coverage and review of left main and imaging as well as physiologic assessment of left main disease.